Syphilis is a sexually transmitted infection caused by a spiral-shaped bacterium known as Treponema pallidum. Though treatable, its diagnosis can be tricky because of how the immune system responds and how the bacteria interact with our cells. In this video, we'll break down how syphilis damages the body, why we need two types of blood tests to detect it, and how those tests work. Let's dive in. When Treponema pallidum enters the body, typically through mucosal contact or microscopic breaks in the skin, it begins to invade local tissue. This bacterium is a stealthy pathogen. It lacks many surface antigens, making it hard for the immune system to detect it early. As it multiplies, the bacteria burrow through tissues and blood vessel walls using a corkscrew-like motion. This physical invasion, along with the body's immune response, causes cellular destruction. Infected tissues start to break down, releasing inner components like mitochondrial lipids, including a substance called cardiolipin, along with cholesterol and lecithin from host cell membranes. These molecules aren't foreign in a typical setting, but when released inappropriately and in large amounts during infection, the body mistakes them for threats. The immune system responds by producing antibodies, not against the bacteria directly at first, but against these leaked self-components. These antibodies are called Reagan antibodies. Now here's the important part. To detect syphilis, we don't rely on just one test. We use two different types, non-treponemal tests and treponemal tests. Each serves a unique purpose. Non-treponemal tests such as RPR, Rapid Plasma Reagan, and VDRL, Venereal Disease Research Laboratory Test, do not detect the bacterium itself. Instead, they detect the Reagan antibodies I just mentioned. These antibodies react with lipid antigens like cardiolipin that were released from damaged cells. So these tests measure the body's inflammatory response, not the pathogen. These tests are inexpensive, quick, and can be used to monitor disease activity because they give a tighter value. For example, 1 to 8 or 1 to 64. A higher number suggests more active disease. If someone is treated, we expect the titer to fall. If it rises again, we worry about reinfection or treatment failure. But non-treponemal tests aren't perfect. Because they measure antibodies to common lipids, they can give false positives. Other conditions like lupus, pregnancy, or even certain viral infections can cause a positive result. That's where treponemal tests come in. Treponemal tests are designed to detect antibodies that specifically target Treponema pallidum. These include tests like fta-abs, TPPA, or enzyme immunoassays. They're more specific, and once positive, they usually remain positive for life, even after the infection is treated. That's why we don't use treponemal tests to monitor treatment. They confirm that someone has been exposed to syphilis at some point, but they can't tell us if the disease is active or recently treated. So how are these tests used together? In the traditional testing algorithm, we start with a non-treponemal test like RPR. If that's positive, we confirm with a treponemal test. In the newer reverse screening method, we do it the other way around. Screen with a treponemal test, and if that's positive, we run an RPR to see if the disease is currently active. Let's compare the two main non-treponemal tests, RPR and VDRL. RPR is a macroscopic test. It uses charcoal particles so the clumping or flocculation can be seen with the naked eye. It's easy to run, fast, and widely used for routine screening and monitoring. VDRL, on the other hand, requires a microscope to detect the reaction. It's especially useful for detecting syphilis in cerebrospinal fluid, so it's often the test of choice when we're evaluating for neurosyphilis. Both tests use the same antigen, cardiolipin, lecithin, and cholesterol, but differ in how they're read. Syphilis progresses through 4 clinical stages, each with different symptoms and treatment approaches. First, primary syphilis usually appears about 3 weeks after exposure. The hallmark is a painless genital ulcer, called a chancre, at the site of inoculation. Treatment is benzathine penicillin G, 2.4 million units IM once. Second, secondary syphilis occurs weeks to a few months later. Symptoms include a diffuse maculopapular rash, often involving the palms and soles, mucus patches, condyloma lata, and systemic symptoms like fever or malaise. Treatment is the same, benzathine penicillin G, 2.4 million units IM once. Third, latent syphilis is a stage with no symptoms but positive blood tests. If it's less than 1 year since infection, it's early latent. If it's more than 1 year or of unknown duration, it's late latent. For early latent, treatment is benzathine penicillin G 2.4 million units IM once. For late, latent or unknown duration, it's benzathine penicillin G 2.4 million units IM weekly for 3 weeks. Fourth, tertiary syphilis can occur years after untreated infection. This stage involves gummatous lesions, cardiovascular damage like aortic aneurysm, and sometimes neurosyphilis. Treatment for cardiovascular or gummatous disease is benzathine penicillin G, 2.4 million units IM, weekly for 3 weeks. Neurosyphilis and ocular syphilis involve the central nervous system. Symptoms may include vision or hearing changes, cranial nerve palsies, or confusion. Treatment is aqueous crystalline penicillin G, 18 to 24 million units per day AVOR, divided every 4 hours for 10 to 14 days. For penicillin allergic patients who are not pregnant, doxycycline 100 milligrams twice daily for 14 to 28 days may be used in certain stages, though desensitization and penicillin are preferred, especially in pregnancy or neurosyphilis. So to summarize, syphilis causes tissue injury, and the immune system reacts by producing antibodies. Non-treponemal tests like RPR and VDRL detect this inflammatory response, while treponemal tests confirm exposure to the bacterium itself. Together, these tests help clinicians diagnose, confirm, and track treatment of this easily treatable but potentially serious infection. If you found this helpful, make sure to like, subscribe, and check out our other videos on STIs, lab interpretation, and infectious disease treatment. Thanks for watching.